So this patient who was started on frontline ibrutinib as part of a clinical trial initially did very well. She had response in her symptoms. The left upper quadrant pain went away, her palpable spleen went away, and by about 18 months on therapy, she achieved complete response by exam and was feeling well. However, she had developed atrial fibrillation as a complication associated with the ibrutinib, and despite multiple interventions and working with a cardiologist, she was unable to continue on the ibrutinib. And then by the spring of 2017, she had to stop the treatment. Though she did okay for a couple months, pretty quickly and unexpectedly, she progressed again, both in her palpable splenomegaly and symptoms, as well as her cytopenias. And at that point, she returned to discuss next lines of treatment. At that time, in discussing her treatment options, and importantly considering that she had the deletion of 17p, we repeated her organ function, and with a normal creatinine, elected to start the patient on venetoclax-based therapy. When patients with CLL who are treated with frontline therapy then relapse, in general, I recommend repeating the FISH panel. And the reason for this is for patients that don't have 17p at the time of diagnosis, often we can see that change when they present with relapse disease. I also recommend checking a full panel of chromosomes or karyotype, as we're increasingly recognizing that patients that have complex karyotype overall have a lower duration of response to some of the targeted therapies. This patient, however, we know at the time of diagnosis had a mutated, we know this patient at the time.
Talk over each other.
Oh.
Just take a pause and stop.
However, we know this patient had a deletion of 17p on their FISH panel. I would still recommend repeating and checking for a complex karyotype. At this time, we don't have a full understanding of the other prognostic markers that may be important in understanding the duration of response to venetoclax.